you're sort of remembered for the rules you break. I think that's a Phil Knight quote. And you have to break rules to do something that's transformational. You have to be willing to fail. And I was willing to do all those things. However, I felt I was on an island because most GI docs would never give up a comfortable living doing something that over time, I'm not saying it's easy. It never is. Any day in medicine has its challenges, but it's comfortable. And so it was really, for me, very important and impactful to be in a space where people were thinking about doing the same sorts of things. I thought that was wonderful.
Dr. Russ Arjal, a very, very warm welcome to the Scope Forward show. I've been looking forward to doing this interview for a long time. I'm glad that we're doing it. Once again, by way of introduction, you are the co-founder and chief medical officer of Telebelly Health.
Thanks, Praveen. Thanks for having me on. I've looked forward to this for a long time, and it should be a fun chat.
So Russ, as we get started, I have a digital assistant, Jenny, and I want her to introduce you. So I thought, let's have fun here. I think you can see her. So she's going to
We have the
introduce
privilege of introducing a true rock star in the world of gastroenterology, Dr. Russ Arjal. Hailing from the prestigious University of Colorado, Dr. Arjal soared to new heights, completing his fellowship in 2008. He then became a pivotal force at Puget Sound Gastroenterology in Seattle, leading the team to incredible success. But wait, there's more. As vice president at Gastro Health, he was instrumental in expanding its national presence after its 2019 merger with PSG. A shining star in the American Gastroenterological Association, Dr. Arjal's contributions to numerous boards and committees are nothing short of legendary. And now, for the most exciting part, he's co-founded Telebelly Health. As their chief medical officer, he's revolutionizing the GI space, blending cutting-edge technology with top-notch care. Telybelly is on the rise, and we can't wait to see where Dr. Arjal takes it next. Give it up for the phenomenal Dr. Russ Arjal.
Praveen, she's being way too kind to me, but that's thanks for the introduction, Jenny.
She'll any day do a better job than I do. So I thought this would be a fun thing to start us with. Russ, it's very exciting. First of all, congratulations on the journey that you've undertaken of starting up a digital GI startup, and it requires courage to let go of private practice GI and take the plunge. I want to understand this story a little bit more and get into your mindset. Was there a pivotal moment? Like, did you always want to do a startup? Like, did you chew on it for a long time? What made you get started?
It's a great question, and it's something I reflect back on still. It takes some time after you've done something sometimes to have clarity. So, it's an idea I had for a long time, really starting in about 2016. That was 8 years after I finished my fellowship. I had built up, some scar tissue at that point. You start seeing the errors of access that are all around you, while at the same time being sort of focused on the diagnostic errors that are pretty rare in GI. And I was seeing innovative things happen all around me, but I hadn't really seen a change in how patients access our care. And that was leading to negative outcomes. You have patients, frankly, that, it sounds dramatic, but people metastasizing in line. And all the while I was seeing things happen in the world around outside of GI that were focused towards speed and things being smarter. So I had thought about it for a long time. It really took me until the pandemic, seeing that we could take care of most GI patients really well. The physical exam was not required for the majority of GI patients, to really get the courage up to leave. So, it was a combination of sort of ruminating on an idea and then having firsthand experience that you could take care of people well. And, at the end, to be honest, it was something I just had to do. It wasn't something that I was calculated about. I just felt I had to do it. And when I did it, people thought I was crazy, and I think still do. And it's been a wonderful journey. I have absolutely no regrets. And I think courage may be too strong a word. I think there's some you have to be a bit naive as well, and you have to just really, it has to be something that you just can't not do, and you have to go all in. To be honest, you can't build something from scratch. I'm not a believer in that. I think you have to jump all in. You have to be completely focused. It can't be a hobby for you. It can't be a side gig. I really think if you're going to try to do something, which is what I want to do, is something transformational, you have to just put all the chips on the table.
I want to delve some more, but just for some context for everybody watching or listening, can you talk a little bit about what Telebelly Health does today? What is the company about?
Yeah, so we are about access. So in general, we saw these market inefficiencies. I'd seen them firsthand in GI and for years, where it was incredibly hard to gain access to care, and that led to all sorts of problems. So really our fundamental purpose, our mission, is to make access simpler and seamless. So we had multiple choices. When we came out as a platform, we could have partnered with any number of entities in the GI space, payers, other companies, but really we wanted to partner with practices. In general, these practices didn't have many partners out. There's risks of disintermediation all around them. It's tough to be in an independent practice, to be frank. It doesn't mean you can't be successful, but there's a lot of friction. And so we wanted to partner directly with practices, increase their capacity, and we thought we could do it with remote staffing. And that's really where we've started, where we source nationally for GI experienced advanced practice providers. And it's a white labeled offering where we then plug them into a practice. So we source nationally and then work locally. And what that does is it increases the capacity of a practice to see patients, and it can be dynamic. People can go up, turn the nozzle up or the dial up, or go down as much as they need. And that's where we've started. Now we want to go further than that, but that's the beginnings of this.
And to clarify, this is an entirely virtual program. Its operations are all virtual.
It's a complete virtual program. We have these brick and mortar partnerships. We are just not believers that you can do this. You can perform high quality GI work just completely in a virtual space. You need to have brick and mortar partnerships. And so we're partnered with groups. So we collaborate with the right kind of groups, to be honest, the innovative groups that are looking around the corner. That's who we want to partner with. And that's what we've done so far. But we partner directly. We offer a white labeled service, and it's a turnkey operation where our APPs, who are coast to coast, will plug into groups locally and then see patients on their behalf.
Someone who's listening might be thinking, why couldn't you do this within private practice setting? You could have started an initiative. You were part of a large entity. So maybe that makes it harder, but I still want to ask this question, why not do it within the setting? Because some people probably are trying to do something or the other within the groups that they already are part of. Like, why leave everything and then, go all in, like you said?
Yeah, I think you can. I think it's not the focus of GI practices. That's one thing. It's a completely different space. And most revenue in a GI practice, at least today, is on the endoscopy side, where let's say 80% of the revenue of a given practice is. It's a complicated regulatory environment as well to operate across state lines. You have to be focused on that. And you have to, frankly, it has to be an operational focus. It can't just be on the side. And it's a different workflow. So we think that it's a little bit, one, you can do it. A GI practice can certainly create a virtual channel, and if that's what they want to do. Now, what we would argue is that we can, one, do it in a more economic way. We have a very capital efficient operation. We can frankly probably do it cheaper than almost any group that's out there. So when you look at your bottom line, it's something that I think for us, it's our focus and it's all we do. It's probably cheaper for most groups to use us.
I want to talk about funding and money and that kind of stuff. One of the biggest struggles, and in my view, the struggle is a mindset struggle rather than a real tangible struggle. And maybe, people will poke me in the eye after this comment, but I'll still say it. Because what I notice in the GI space, there are many, many talented, very entrepreneurial GI doctors out there that want to do so much, that are capable of doing so much. But it's the money that gets in the way. And it's a multi-pronged problem, if you will. One aspect is, hey, look, I could be making so much more doing these endoscopy procedures like I am. So why should I forego that revenue by going down startup path? That's one mindset. The other is, where do I generate all the money that I need to do something like this? Where's the money to pay myself a salary, hire people, pay them the salary, and how does one even go about fundraising if I have to? How am I going to return all that money? So people may have all these questions in their head. They may not ask them as directly as I do. I want you to reflect a little bit on that. How did you figure it out? How did you solve the funding question for your startup?
I asked for help. The short answer is that I listened and I understood the private equity world, which is a different world than venture capital, and the psychology of venture is totally different. And the macro environment, of course, has changed a ton. Capital was free for a long time. Some of the valuations in 2021 are going to be tough to achieve again for companies. So we were starting this at a time where it's harder to raise. It still is, of course. So I used my network. I got a little lucky. Some of my early investors were people that had started and sold companies that really understood the venture space. They understood digital health. I learned a lot from them, and I built a team. Once we made those initial connections, we raised our initial tranche of angel funding. We built a team, and my goal, I knew my limitations. I gave up my CEO title very early in this. I hired Sherry Rudberg, who's really talented and could have done a lot of things. And getting people on your team that understand the venture space helps a lot. And so we were able to leverage all our networks and able to get people that understood what we're trying to do, get people that truly believe in the mission. This is something that I think people believe in, increasing access. And so in general, that's what we did. And by the beginning, simply asked, I checked in with my network. I met people. I got a little lucky, to be honest. I met Trey Lauderdale, who founded and sold Volt, which is in the medical communication space. Trey is deeply connected, and Trey helped me a lot at the beginning and mentored me. So that's really my story. It'll be different for somebody else, but I think you leverage your network and leverage the knowledge of people that know more about it than you do.
During that phase, did you continue, were you playing Batman? Were you continuing your day job, doing procedures and doing what you did in private practice GI while you were building this on the side? Or were you able to fund yourself to go all in?
Yeah, I did self-fund at the very beginning, and then we were able to raise our first round. I still maintained a practice for a period of time. I still do clinical work, a small percentage of the time compared to my time at Tellybelly. Once I built a team and once we had enough funding, then I really felt I needed to really focus on this full time. And that's all I did for 11 months. I did not do a colonoscopy for 11 and a half months. There's going to be people out there that think it's crazy as a GI doc. There's no way we would have been able to stand this up if I was still working. There was too much work to do and too much to learn. So for a brief period of time, but once I had momentum, I jumped in the pool.
Now, you were part of the GI Mastermind cohort for 2022, and you were a very keen participant. And it was fun to have those interactions with you. And you always brought about the contrarian view in our discussions, and I thoroughly would enjoy that. My question or a reflection, rather, was what did you take away from it? How did you implement it? You had already started Telebelly Health by then, and how did you use it to shape your thinking to what you were doing?
Yeah, it was a very valuable course for me. And again, when I talk about luck, I had luck there because I joined the course at just the perfect time. And it was a place where the mindset was very different than where I'd been for a long time. That's not meant to be critical. GI is a very successful operation. And in general, if you run a successful clinic, it is a great business operation. And I enjoyed doing that for a long time. But it is a relatively narrow focus and focus primarily on endoscopic revenue. That's really what you're doing in a GI business. So joining the mastermind course where people were thinking in different ways, looking around the corner, taking chances, and really having a more, as you've put it, an exponential mindset, that was very helpful for me, for my own, just the function of my own mindset. One, it reinforced to me that I wasn't completely crazy. There's other people out there and that were thinking the same way as me, but I just never met them. So it was a wonderful community to be part of. And then it also gives you just a broader worldview of things happening outside of medicine. I think we become too close to things. Our mindset is relatively narrow. So it changed the way I looked at things because there's a lot of things that are happening outside of medicine that will eventually apply to medicine that either I was unaware of or just hadn't thought much about. So I thought it was a wonderful course. But more than anything, I thought it was the community and the exchange and the challenge. People would push back on your ideas. It wasn't in a mean way, it was a kind way, but it made you to think and it would challenge you. And you really need to do that as you start moving forward. And the last thing I would say is that, I think you're sort of remembered for the rules you break. I think that's a Phil Knight quote. And you have to break rules to do something that's transformational. You have to be willing to fail. And I was willing to do all those things. However, I felt I was on an island because most GI docs would never give up a comfortable living doing something that over time, I'm not saying it's easy. It never is. Any day in medicine has its challenges, but it's comfortable. And so it was really, for me, very important and impactful to be in a space where people were thinking about doing the same sorts of things. I thought that was wonderful.
Was there a certain pivotal moment or an aha that you experienced that comes to mind, during the year that we spent together? Like any one thing, that really stood out, one moment, one conversation, one line, something that somebody said or you said, or
I don't know if there's one line that stands out. I thought there's a lot of common themes. I think the discussion about artificial intelligence, which were happening, in a way that was right before, the large language models really started coming out in November. It was sort of in parallel. That theme was present throughout the course, from video snippets to movies to just discussion. And that's really what stuck out to me. I hadn't really, it was something I was curious about, but I'd never really delved into. So if I was going to pick one take, really be those discussions that we had.
Very interesting to know. Let's get back to Telebelly Health. You talk about access. You talk about, solving the problem of access. I want to understand this more from the patient's point of view. I'm sure you saw it. You saw the need. You saw the trouble that patients were having because they were not getting access to GI care or the right care or at the right time. Maybe the waits were long. Want to understand a little bit more, and if you can take specific clinical examples, I think that'll be great.
I'll just start with my own. When I was first thinking about this, 2016, I had a 42-year-old software engineer at Microsoft who had rectal bleeding, completely healthy. It took him 3 months to see me. His primary care doctor did all the heavy lifting. She convinced him that it may well be a hemorrhoid, but it could be something else. 3 months to see me, a busy guy with a young family and a job that took up a lot of his time. Another 3 months to have a colonoscopy. And, this is one of these dramatic stories where we lost control during this 7-month wait because the source of bleeding was a rectal cancer. And it's just the worst thing. He had a couple young daughters the same age as my 2 young daughters at that time. I mean, it's just, I still think about all the time. And so that's just a story of where it's a dramatic one, but he didn't have to wait at all. There's no reason for a physical exam in that case. That was purely ritual. Billing maybe a little bit at that time. He should have seen not a physician, but a GI APP. He should have had a colonoscopy months before. And maybe it changes the outcomes because in his case, his disease was metastatic at the time of diagnosis. Now, I can't say 7 months didn't change that outcome for him. But we've seen that story multiple times, even in our first, let's say 500 patients we saw, which is a long time ago now for us. We saw several malignancies for patients, and what changed for them was that their journey went from 4 to 6 months going through the process of, it's like going to Blockbuster for a video, right, versus Netflix. 4 to 6 months for a problem that was simple, but the fundamentals were really serious malignancies in these cases. And we saw, instead of being 4 to 6 months for these patients to be diagnosed with a colon cancer, let's say, or a gastric cancer, I'm just thinking of the first few cases. Those journeys went to several weeks. They saw somebody a few days later after they made the visit, after they referred. We were able to schedule them for a procedure. And I think that materially changed their outcomes potentially. So those are just some examples we had early on. And we've seen lots of those. There's a lot of pathology in line, in the queue waiting to get into a GI clinic. I use the analogy of it's like one queue to get into the amusement park. And everybody's there. And you're waiting 100 days, let's say. That's what, the waits to get into a GI clinic right now are anywhere from 3 to 6 months typically. And so a lot of really terrible things are developing during that 3 to 6 months. And it just doesn't have to be. We can see those patients much sooner get them the care they need, move them through, and this benefits groups and patients. So that's really what we've seen early on in our journey. And over time, we think we can make these visits even quicker and smarter. But even when you just replace brick and mortar visits with GI APPs and move that visit up months, that really changes the outcomes for a lot of patients.
Let's delve into it a little bit more, just for clarity for everyone listening. So there's a patient out there, and so he or she can't get an appointment. So this example that you took, what would happen in a Telybelly world? So he would reach out to you, he'd go to your website. How exactly does the person see your APP, and what does the APP do in the consultation or interaction? I just want to understand the operational model or the flow.
That's a good question. So this is a white labeled offering, meaning these are not our patients. We are seeing patients on behalf of the practice. And the patient is scheduling through the practice, calling in usually for clinic visits. They're then offered choice. Virtual visits are not for everybody. Not everybody wants them. They're not appropriate for every clinical use case, but patients just sometimes want to be seen. And so they're given a choice to see Dr. Smith, let's say, when she's available in 90 days, I'm just making this up, in Lancaster, Pennsylvania. Or they can see somebody that's virtually and have their questions answered, their workup started. Now, they are not told this is a Telybelly. We are a white labeled service, so we are just an extension of their clinic, but they'll then be offered a virtual visit, usually days later, with one of our providers to start the workup. Now, that provider may be 3 time zones away and seeing patients in that local clinic. But that's the way it works now, where we use the scheduling, what I'd call apparatus at the clinic. We are documenting the EMR of that clinic. So we have full visibility, and our partners have full visibility, and we are seeing those patients quicker. That's really what we're doing at this time.
As far as labs and everything else, so does the patient have to visit the practice and give it, or is it all also remote? How does that get into the EHR of the practice in a virtual visit?
Yeah, so we are ordering through their EMR. So if somebody is on Epic or G-Gastro, we are ordering labs. We are using the infrastructure of the practice, so an MA. So if we order a CAT scan or a set of blood work, we'll go through the labs or imaging center that they normally use. It's the same workflow. We mirror that. If we order endoscopic studies, and a lot of these visits do convert to endoscopy, it's just a key tool that you need to take care of GI patients. That's the reason I don't think you can do this completely virtually. You really need partnerships. Then we'll order studies that will be typically done at the ASC of our partner practice. So it's really mirroring the workflow. We are just an extension of the practice. We are white label to the patients. They are seeing somebody who's affiliated with the practice, which creates immediate trust. As a result, we have a huge focus on making sure we're doing great work, and our quality program is robust. We know we have to deliver A+ care. But that's really how we work right now.
And what's the business model? How do you get paid?
Yeah, it's a good question. So different ways to go about doing this. I'll give you sort of the longer answer to this. Initially, we had thought we were going to be a direct-to-consumer company. I really think that the customer acquisition costs, you have to have a lot of capital to do that. We realized that very early. So we are a B2B company. We work directly with GI practices to do the things we've talked about. We assign billing rights to those practices. We are working within the world of insurance. I think that's, for better or worse, there's some out there that would argue that you have to blow up the whole system to have a reasonable system. That's not pragmatic. So we assign billing rights. We credential our providers with the payers that these practices have. They're really a member of the team. We just are turnkey service. We manage those providers. We provide cyber medical malpractice, the physician supports. We plug in. And those practices then bill on behalf of our providers, and then we have a per visit fee that we charge those practices. That's our business model, which is where we started. The way there's different things you can do, but it's been the simplest way to get traction. And the practices in general benefits. There's margin for them on the initial case. There's of course a lot of downstream revenue, since most GI practices are making 80%, let's say, of the revenue on the endoscopy side. And for us, since we run an efficient operation, we think it's a win-win-win situation with this model.
There's a tech play here. You're excited about your new CTO coming on board. So I want to understand what the tech platform is currently, or what are you planning to build, whatever is okay to share, of course. How is it going to evolve, and what role does technology play in what you do?
We really are interested in becoming a tech-enabled services company. Right now, we are providing services, but we have put our chips down that we really think that we need a platform to offer not just quicker visits, but smarter visits. And so right now we're starting with really pretty simple processes. We are automating and digitizing, for instance, open access colonoscopy, which we are doing in a couple states, and that's been really effective. And that's a good start for us, where a lot of what we do for colonoscopy, which is really the lifeblood of a GI practice, is very manual. It takes a lot of FTEs. Most groups don't have the staffing to do this efficiently, and you can digitize a lot of that. Now, over time, that's really our first product on the software side. We've built out a team. We've hired our first developers. We have now a CTO that has done this in the virtual space. We are, over the next year, we're building out a software platform. We think there's a huge need for intake, and we think you can automate some of that intake, and there is a place for machine learning and all that. And that's beyond just sort of the buzzwords of it all. There's just a lot of protocolizable GI conditions, and patients at this point, their intake is really very simplified. And we think we can make that more sophisticated. And on top of all that, we need a place where our providers live. Since we're a company that really will be national, there's nuance to that. There's supervision requirements depending on the type of clinician you have. So it's a place where, although we're not building an EMR, we are building a specially specific platform. But that's something we're actively working on.
All the best for that. I'm excited to see how this all transforms and evolves. As we wind our conversation, Russ, I want to get to certain broader questions, if you will, and more industry related. Like, so if you pull back from your role currently, as the Chief Medical Officer for Telebelly Health, and as a startup co-founder and all that, if you take a step back, and if you just think as someone belonging to the GI industry, what kind of problems frustrate you? What frustrates you about GI as a space?
Well, I think we're too comfortable. That's frustrating in the sense that I think we run the risk, and I'm just putting my gastroenterologist hat on, of being disintermediated. And I think that there's a lot of threats out there that we, at this point, because of our focus on really a singular test, we do many things in a GI practice, but the lifeblood and the economic model is based on, colonoscopy. And colonoscopy, I think, is at the risk of, I don't think it's going to be disruptive. There's always going to be a need for colonoscopy, but not every patient wants a colonoscopy, of course. And there's other tests out there that are non-invasive tests, from DNA tests, RNA tests, to liquid biopsy that are around the corner, that I think will put some pressure on, our sacred cow. So frustration may be too strong a word, but I think we are too comfortable in what we're doing. I think the GI space will evolve considerably over the next 3 to 5 years. That's just me speaking on behalf of me, my own opinion. I guess what is always difficult with physicians, and I'm one of these, is that we hate change. And that's always frustrating, because what happens then is you lose agency, you lose control, because people change quicker than you. So I think there's a ton of opportunity for GI out there. I think we, as a group, are slow to change. And the last thing I would say is that, and this is something I used to say at the board meetings all the time at Puget Sound Gastroenterology, where people would always talk about, when I say people, physicians would often bring up this idea that, well, that's not what I want to do. That doesn't really matter, to be honest. It's that the market will bear that for now, but it won't bear that forever. And so my feeling is that we have to be more adaptable. We have to be more open-minded. And we have to be willing to change. And if we don't do that, we do run the risk. I don't think it'll be a mass extinction event, but I do think we run the risk of becoming less important and losing our seat at the table, and maybe losing some of the financial benefits of being in the space, because it's been a long bull market for GI. And I think there's still room to run, but we have to change our thinking, at least.
What you said about the meetings, that someone might say, but that's not what I want to do. Can you explain that a little bit more?
Yeah, so there's things that patients want that physicians don't want. A great example is non-invasive stool testing, right? Patients like Cologuard. 95, I think, percent of patients 45 and up have seen an ad for Cologuard. Of course, the market share is going up. GI doctors in general have been, and I'm not speaking for everybody, have pushed back that Cologuard is not the same as colonoscopy, and that's true. Colonoscopy is the gold standard. And we, as GI doctors, think that everybody should have a colonoscopy. That's a nice idea, but that's a fantasy. That will never happen. And there's not even enough GI doctors and enough endo space to do all the colonoscopies that are out there. And so that's a great example where if I push, and I'm just saying this is a hypothetical, I think the best way to screen a community is a two-step process. That's what our societies have put out there, that we should give patients choice. And we should perform colonoscopies in patients who appropriately need them and want them. But if they're not going to be screened, then offer them an alternative that they'll accept. And the best screening test is the one that gets done appropriately. But if I said that at a board meeting, I would get a lot of pushback that, that's not what I want to do because colonoscopy is the best test. That is true. Colonoscopy is by far, with a good operator, is the best test. But that's totally different than what many patients want. So I just think I don't know if that's an example that's perfect, but the idea is that what we want as clinicians is just one side of the coin. What patients want is frankly more important, and that's what will drive the market. And I think if we are too focused on what we want, we run the risk of being outrun by other competitors who are focused more on patients.
In the GI Mastermind program, we talk a lot about mindset and we delve a little bit into that. So I want to touch upon that a little bit. So why is that? Why is it that physicians afraid to go there? And I'm using that word very broadly. So is there a fear here? What's going on in the minds of the gastroenterologists who are pushing back and saying that, no, I'm not going to do this, or you're thinking incorrectly, or whatever, they might say anything. But why is that?
I think there's a few things. One, we're at the mercy of all our training, where it's hard to get a GI. It's a very competitive field. It has been for the last 15, 20 years. And so there's a ton of talent in GI. The younger GI docs have worked, I'm not saying the older, the 60-plus-year-old GI docs. And by the way, GI, as you know, is an older space. The median age is about 57 and a half. That doesn't help patients. But it's hard to get a GI. It's a lot of training. It's training that results in a nice, comfortable existence. But you're only doing, it depends on, again, colonoscopy being at the same place at the table as it is now. So I think it's really hard to change as a physician when you spend so much time to become an expert. It's an apprenticeship. And so you can't get those years back. I think that's part of it. I also think it's just the personality type, honestly, where people that go into medicine, they could have gone into finance or something else, and they would have been more risk takers probably, and they would have been making markets. They went into medicine. And so it's a different sort of ruminating mindset. So I think part of it is just the personality of doctors who tend to be risk averse, if you're going to generalize, not every physician, and the amount of training. So there's a lot of risk. If you're going to make a change, I mean, people were right to call me crazy for doing something different and leaving my comfortable spot at the table, because I had spent a lot of time getting there, and to take on uncertainty. What I would say is the training time is maybe the biggest variable. And also, I think it's personalities. I think in general, we're sort of, we're nervous creatures, but we are careful creatures.
Yeah, the training, I think, teaches physicians to be so, for good reason. So talking about the industry risks, that you touched upon, how many years, do we have before you would sense a disruption at scale?
I think it's impossible to prognosticate. I think in the next 3 to 5 years, we're going to see a lot of change. I don't think colonoscopy will be completely disrupted. There's always going to be a role. I do think average risk patients may choose liquid biopsy and stool DNA and or RNA testing. That market share will go up over the next 3 to 5 years. I think we'll be doing more diagnostic colonoscopies over time. There's still maybe 60 million, 45 to 60 million Americans who haven't been even screened, who need to be screened. So We're still going to be doing, I don't think we're going to stop doing colonoscopies, but I do think just the average risk screening colonoscopy population over the next 3 to 5 years, there's going to be, the market share will change. I think liquid biopsy is potentially an existential threat. I think Cologuard 2.0, when it comes out, I'm assuming it'll get FDA approval. I don't know, but that's just my assumption. I think that will continue to get market share. Patients want non-invasive testing. That's just what they want. And so if I was a young physician, yeah, I mean, going into GI, I would be thinking about the next 5 years. And I think in 5 years, the field will be very different. And just going to sort of, if you don't mind, just thinking about just timeframes here, where a young physician coming to GI has a 25-year horizon, right? A private equity group has maybe a 5-year horizon. Maybe a venture group has an 8 to 10 year horizon, right? And so there's a mismatch between where people are that control these entities. So if I was a younger doctor going in, or an older doctor, I would really think about my skill set going in, because I think in 5 years, just to circle back to your question, I think 5 years, the practice of GI will be very different. I don't think colonoscopy will be disrupted away, but I just think we'll be doing more diagnostic studies and maybe be a more cognitive field than we are right now.
So, Russ, my final question to you is, you touched upon a lot of these themes, but I want you to summarize and say it. Like, so my question is, if you have to reimagine GI care for the future, what is the future of GI?
I think reimagining care for me is still what is the forefront of my mind is access. I think you should be able to get a GI clinician on your terms within minutes. I think that's something that will happen eventually. I think that's something that's possible. I think those visits will be smarter. I think there'll be intake processes. I think, again, for the structured problems that constitute the majority of GI visits at a community practice, you can protocolize a lot of those. And I think AI will be something that's important. And I think that all of us will have an Iron Woman or an Iron Man suit on as we make decisions in 5 years. I think that's what will happen, not with GI, but in other verticals as well. I think all the principles we're talking about in GI work for most other specialties as well. This is not going to be, we won't be the first sort of wrap around the practice company out there. There'll be others, and I think there'll be others in multiple specialties. I think GI, bigger picture, will be a more cognitive field. I think right now we've been focused on a singular test, and that's a very useful test that's life-saving. As we just talked about, I think there'll be different screening programs. I think there'll be more two-step screening. I think there'll be more value in the space. And I think that will force us to take on more diagnostic studies. And I think we'll pivot back to sort of the roots of GI, which GI for the 60-year-old gastroenterologist was a much more cognitive field and less procedural than it is now. We'll still be doing procedures, but I think we'll be more focused on the clinic space. And I think we'll be thinking more about root cause analysis, because that's what patients want. Going back to some of these thoughts, we have a procedural mindset. Procedures are really important, and they're very helpful for folks, but patients often have a root cause mindset and those patients aren't well served by practices often, or clinicians. I don't think I did a great job in my career taking care of those patients and answer those questions that are hard to answer. So I think that's where we're not going to pivot, we're going to morph.
Awesome. Dr. Russ Arjal, co-founder and chief medical officer of Telebelly Health. Thank you so much for coming on the Scope Forward show. This has been amazing. As with every interview that I do, I end up learning a lot. Really, like, your perspective was very clear, very open, and thanks for sharing everything that you did.
Praveen, pleasure. Thanks for hosting me, and thanks for starting all these conversations. The GI Mastermind, it's been, I think, great for the community, and appreciate you allowing these sorts of conversations, giving us a platform to talk and build a community. I think it's really helpful.